Hi there, I'm Karine Tawagi. I'm a genitourinary medical oncologist at the University of Illinois in Chicago. We're here at ESMO in Barcelona.
I'm Chris Wallis. I'm a urologic oncologist at the University of Toronto, and I'm really glad to be joining you and chatting about the latest data we've seen in the last couple of days.
Yes, we've seen a lot of exciting data. So first we want to talk about some bladder updates. So could you tell me briefly your thoughts about Sunrise-1?
Yeah, and so, we come to ESMO, it's very med-onc heavy, but I think there's a few bones that were tossed to the surgeons here the last couple of days, and Sunrise-1 I think is some really interesting, really promising data. So just for context, this is the BCG refractory non-muscle invasive bladder cancer space, CIS patients with or without papillary disease. This is a really difficult patient population to manage. They're used to intravesical therapies, they're used to small local bladder-directed therapies, and by the time they get BCG refractory, the only thing we know in our guidelines is radical cystectomy, taking out their bladders, and that's a really morbid step, and a lot of patients don't want to go there.
Right.
We obviously have a few other intravesical options approved, and we have obviously Pembro as a systemic option approved, but we're looking for better because at the end of the day, the clinical outcomes are just not that good with what we currently have. And so TAR-200 is the device tested in Sunrise-1, and it's an intravesical pretzel that emits low doses of gemcitabine over a sustained period of time. So you get prolonged drug exposure to the urothelium, and that idea being that will lead to better disease control. And so what we saw is really, really promising data. So we saw 12-month CR rates exceeding 85%. We think back in like 2015, 2016, the FDA set a benchmark that we have to hit at least 25% for something to be considered, meaningful. And now we're looking at outcomes that are more than 3 times that. And so I think that's like a really huge, huge step forward. And I think forms obviously the basis for many other ongoing trials. We have Sunrise-2, 3, and 4. And then it also opens us up as just a drug delivery platform. So obviously the current device emits gemcitabine, but we have Moonrise trials coming, which is going to really walk that line between med-oncs and urologists again, where there's a device component for the urologist, but it's a drug that the medical oncologists are maybe more comfortable with. And so I think this is early days, but I think we're probably coming to registration not that far off, because single-arm studies are the accepted registration pathway for this disease space. And so I think it's really, really interesting and really promising data, and a real big opportunity for us to give good disease control and preserve the bladders for these patients.
No, definitely. And like you said, it's one of the highest response rates we've seen in terms of bladder sparing options for those patients. And so we're going to be hearing more about this device in Sunrise-4, which will be talked about tomorrow in the muscle invasive bladder cancer space. And so speaking of muscle invasive bladder cancer, we heard about Ambassador updates today. What were your thoughts on that?
Absolutely. So just for context again, Ambassador being adjuvant pembrolizumab for patients who've had resected muscle invasive, typically bladder cancer, but upper tract was also allowed. I think this is a difficult disease space. We try to get as many of these patients neoadjuvant chemo as they can before surgery. And so for those who have persistent muscle invasive disease after their neoadjuvant chemo, that's obviously a poor prognostic feature, and that's something that worries us. If we've given them a good run of cytotoxic and at the time of resection they still have residual muscle invasive disease, we really worry. And so to have the existing data, we know that Nivo is an option in this space based on Checkmate 274 data. And so Ambassador gives us, I would say, very comparable data to 274 for pembrolizumab. So again, we're seeing DFS benefits, we have immature OS benefits, or lack of benefit probably to date. But I think for this patient population, DFS is a pretty meaningful endpoint. By the time a muscle invasive bladder cancer patient has disease progression after surgery, we're really talking about palliative options. And so keeping them off drug with an adjuvant course, I think, is a really huge opportunity. Now, is it practice changing? Probably not, because we already have Nivo available to us. But I do think it adds another tool to the arsenal. There's some other data we've obviously seen moving later in disease space. We saw EV updates, really, that I think didn't change much for us, confirmed that ADCs are here to stay, but there's new ADCs. And so what do you think about the HER2 targeting?
Yes, so this morning Dr. Galsky spoke about disitamab vedotin, a HER2 antibody drug conjugate in combination with pembrolizumab. and they showed that in both HER2 high and low, they were seeing in the first line untreated metastatic urothelial carcinoma population response rates over 70%. So I think it's exciting to see, biomarker-driven treatments in metastatic urothelial carcinoma, but how will it compare to EV Pembro in the frontline setting? We don't know. There's going to be a larger phase 3 trial comparing DV with Pembro versus DV alone. So definitely be looking forward to that data.
Absolutely.